Thanks a lot, Rupert, and thanks to Sarah, Rupert, and Jack for the invitation to do this today. It was really a pleasure to be invited to do this. I'm from the University of South Australia in Adelaide, Australia, and my work is using modelling and simulation, or we call ourselves pharmacometricians, to analyse data. So we offer a bit of a different perspective to a traditional statistical approach, because what we're actually seeking to do there is to describe the system rather than the outcomes. So the outcomes are a result of a system. There's a series of things that happen that generated those results, and we try and describe those. That makes us what we call pharmacometricians, quantitative pharmacologists. So this paper that I'm going to present today actually stems from this original clinical trial here, where Paul Glue and Colleen Liu were running with their co-workers, ran this trial where they were looking at a variety of different routes of administration and a variety of different dose levels of ketamine in treatment resistant depression. And one of the people on the team was Andrew Somogyi, who's my old Ph.D. supervisor, and he could see that this kind of data was begging for a sort of pharmacometric analysis, a modeling and simulation analysis, because it had everything that we would really dream of there: different routes of administration, different dose levels, treatment refractory depression, with the three routes of administration of intravenous, intramuscular, and subcutaneous. And each of those participants in that trial were dosed at least 1, but up to 5 different dose levels, from 0.1, 0.2, 0.3, 0.4, 0.5 milligrams per kilogram, where the doses were effectively single doses. They were separated by at least a week or more, depending upon when their depression scores returned to pre-dose levels. And so what that meant was we had 61 treatment sessions across 21 participants, and they collected pharmacokinetic data for ketamine, norketamine, and also the pharmacodynamic data looking at depression scores, some MADRS scores, I'm going to call them, otherwise I'm going to be speaking for a very long time if I pronounce the full name, and heart rate and blood pressure. And so this was a real privilege to be able to have a look at this data and try and develop some models from that. So the demographics of the people, the twice as many males and females, average age around 50, but a bit of a spread. They also collected cytochrome P452B6 genotype data, because there's some belief that this is important in affecting the clearance of ketamine. And you can see that we had a fairly reasonable amount of data here. So all but 2 of the subjects, we had everything measured for, with about 300, on average 300 observations in the data set, with on average somewhere between 13 and 17 observations per subject. So this was really, really great data to have access to. And you can see that these are collected at a variety of times. Not everybody had a sample taken at every point in time, but this is the sort of spread of data that we had across the study. And so what we're trying to do here with population modeling is what we actually call it, population pharmacokinetic pharmacodynamic modeling, PK/PD modeling, is in a normal fashion. We're all used to this idea of, I guess, a model is a mathematical equation or a series of linked mathematical equations. And we can do that to describe an individual concentration time curve. Probably some of you clinicians are forced to see some equations way back in undergrad. And so we can use some of these mathematical relationships, but we take that one step further. We don't treat the individual as the unit of analysis. We take the population as the unit of analysis. So we're we've got sort of a drawing of what we could see as a model of pharmacokinetics, where the dose is absorbed into what we could call a central compartment, the blood and rapidly equilibrated tissues, and the drug can distribute into other more slowly equilibrated tissues, and the drug's eliminated from the blood or plasma. And so we're seeking to identify average values of the parameters that describe the mathematics of this system. But it's not just that. We're actually trying to find the variance of each of these parameters that best describes, that allows for a combination of the average value for each parameter and the variance of each parameter, allowing for a description of all of the people in the population, the best description of the population, not just an particular individual. And that does several things, because it allows us to separate the variance in the data that is accounted for by between person variability, but also the residual unexplained variability that's effectively, I guess, measurement error or the random noise in the system. And we take that a step further again, where we look for potentially explanatory covariates that may explain some of this variability. So the example here, and this was in the final model, is body weight, where clearance is standardized to a standard weight, and it increases or decreases according to any individual's weight. And so that can explain some of that variability. So we're looking for these covariates. So when we have a model, we can then do simulations of what might happen when we change dose regimens or dose sizes, or look at what happens at different values of the covariates to make predictions from the model that we've got that describes that population. And so we did that in our paper. And to begin with, we first built a model for ketamine, which was just a fairly simple model where we had intramuscular and subcutaneous doses being absorbed, and they showed very similar absorption characteristics for the dose. And then I linked that to norketamine, and then we looked at the depression scores, and I'll talk more about how we describe that in a moment. And they were best described as being linked to ketamine. And then I sort of handed this over to my postdoc at the time, Ahmad Abuhelwa, who was just finishing up his postdoc and looking for things to do. So he got involved and checked that I knew what I was doing, and then finished off the modeling, looking at the blood pressure and heart rate. And so it was a very straightforward system for the cardiovascular effects of blood pressure and heart rate. Those effects were directly linked to the plasma concentration, as is the case for many pharmacological effects. But the MADRS score was slightly different, and we used what is called a turnover model here. Now, this turnover model, and I've got a bit of more of a cartoon if people want. I can show that when we're finished in the question time. I think that might maybe explain this a little bit more better with some pictures. But what we have here, if you imagine a burden of anything, this is commonly used, for example, in tumor growth. So we have a burden of something, and the size of that burden is the result, as we're just walking around at our baseline level, is a result of forces acting to make that burden larger and forces acting to make that burden smaller. And a drug may work by changing the production or the elimination characteristics of that burden. And that's what we found for the MADRS scores that explain that characteristic decline and return. And it can allow for a rapidish drop and a slower return, or vice versa, depending upon the nature of the turnover system. When we were looking for covariates, it was actually quite disappointing, because all we really found, and this was a fairly predictable finding, because it's generally true for many drugs, is that weight is a good indicator of an individual's parameters. So these parameters, clearances and volumes, tend to scale with weight. It's got a long history of what we refer to as allometric scaling to body size. It makes biological sense, and there's a lot of foundation in biology to explain why that happens. We're a bit surprised to not see any impact of the cytochrome P452B6 genotype on the elimination of ketamine or the production of norketamine, but that could just be because we didn't have really too many people at the extremes of the genotype characteristics. We found no impact between male and female participants. For the pharmacodynamics, we found no covariates whatsoever that predicted any of the parameters describing the adverse and beneficial effects of ketamine, unfortunately. And I might touch on that a little bit at the end of this talk. So this is a slide showing what happens in the average person for 40-minute IV infusion at 0.5 mg per kg, which is what seems to be a standard protocol here. This is just a single dose though, because this is effectively what we had in our study. And we can see the concentrations peak at the 40-minute mark and then they drop. And we see about a maybe 10 millimeters of mercury transient rise in blood pressure, and something similar maybe for heart rate. You see about a 10 maybe beats per minute increase. And that's very rapid and transient. And when we look at the depression scores, though, we see this very obvious and characteristic decline where it actually reaches a nadir just under a day after starting, despite the fact that ketamine is well and truly gone from the body. And that's the result of this turnover system. That's how we were able to describe that, with the gradual return over the next few days. So this is a table of all the model parameters, and I'm not upset at all that it's blurry. That's not your eyes glazing over looking at some awful mathematics. It's intentional. And so the take home that we learned from the PK was that dosing by body weight is obviously a very good idea. We confirmed that. And we confirmed the obvious, that ketamine is rapidly eliminated, low nanograms per mil within a few hours. But the newer thing that we learned really here is that intramuscular and subcutaneous dosing really have indistinguishable absorption characteristics. It's very rapid, with a half-life of around 6 minutes. In other words, about 90% is absorbed within about 20 minutes, which actually is faster than your 40-minute IV infusion, because that takes 40 minutes for all of it to be absorbed. And so 90% of it's going to be absorbed close to 40 minutes. So this is actually a faster input into the body than your 40-minute IV infusion. But the bioavailability was about 60, about 2/3. We're not sure why that is, but that was a pretty robust number that kept coming up when we tried to describe that. And when we look at the pharmacodynamics, we see, another blurry table. But the point here is that the heart rate and the blood pressure were an immediate effect. There was no delay there. It was effectively directly linked to changes in plasma concentration. But the MADRS scores had this turnover time of similar to like a half-life of around 42 hours, with huge between subject variability, 96% CV across the population. So it's very, very variable. But more importantly was this, and this is really something new that we learned, was that the potency for ketamine is orders of magnitude, 3 orders of magnitude, 4 orders of magnitude more potent in impacting on depression than it is on the cardiovascular effects. And so what do we learn from all of this mathematics at the end of the day is that we learned that the cardiovascular effects are directly, directly linked to the concentration, and that because of the potency, it requires relatively high concentrations to see any effect. And so those peak concentrations that we see after the infusion or after the subcutaneous or intramuscular dose are very important. They are the sole determinants. It requires these high concentrations to cause any cardiovascular effect. But after a very short time, a couple of hours, those low concentrations, they're not relevant at all. They are so low, they are massively below the EC50s that generate these relationships, these effects. And so they have no impact at all. And so it's not surprising that they're short-lived because of their low potency and the very short half-life of ketamine. But the important part here is these peak concentrations are the only thing that matter in these particular side effects. in stark contrast, the impact on depression, those peak concentrations are 6 orders of magnitude above the EC50. They are massively above the EC50 for this. They're causing maximal effects, but they're so far beyond it, they're not really relevant. We only need these low concentrations. Once we're hitting around about the low tens of nanograms per mil, they are relevant because the potency for ketamine is so high on the depression scores that these very low concentrations are still sufficient, being 10 times above the EC50. So these residual concentrations are important, but the peak concentrations are not really relevant at all because they are so far above what's needed to cause an impact on depression. And so what we, to add on to this, is that really the subcutaneous and intramuscular administration are basically the same as IV. They're rapidly absorbed and they achieve similar-ish concentrations. And I'll sort of show that here. So if we have our standard, so what we have is the lines are the average person in these top boxes, and the bands are the 90% confidence intervals or across the population. So we have concentration, depression scores, blood pressure, and heart rate. And down here we have the percent of, this is a simulation from the model, 1,000 people. And then we look at the percent of people over time. This is just after a single dose that will have a MADRS score less than 10 or a greater than 50% reduction. So remission and response, and the percent change across the population in blood pressure and heart rate. So we look at the concentrations with a 0.5 mg per kg 40-minute infusion. They occur around 250 or so. We get similar-ish concentrations after subcutaneous. We see the depression scores drop, reaching that nadir almost about a day after about on average, about a 5 to 7 unit drop. And we see essentially the same thing with the subcutaneous dose. Slightly less of an impact here. And then we look at the percent. So you can see very, very similar, slightly lower percents reaching remission and response for subcutaneous at the same dose as IV. And that's partly because the bioavailability is lower, so there's going to be lower exposure, but the absorption is a bit more rapid than IV, being that very rapid absorption compared to a 40-minute infusion. So we see similar-ish concentrations and similar-ish responses. If we increase that dose, to 0.75 milligrams per kilogram, we start to see much higher concentrations because that absorption is rapid. It doesn't take 40 minutes, it takes 20 minutes. So even though it's effectively the same dose entering the body, because we've scaled for that bioavailability, we do see somewhat higher concentrations. We see a commensurate improvement in the percent of people, okay, that achieve outcomes for depression, but we start to see an increase in side effects in the cardiovascular system because of this increased peak concentrations, but these residual concentrations are what's important. So the suggestion here could be just use subcutaneous dosing at 0.5 mg per kg. It's essentially identical, or 0.6 or 0.7 mg per kg, because it's essentially the same as a 40-minute IV infusion. So looking at previous recordings of these presentations on the Ketamine conference website, one of them, somebody asked this question. It was in relation to, I think, PTSD, but I'd like to just sort of try and address this question and show how modeling and simulation and your local pharmacometrician can be a big help in doing this. And so once we have this model, I showed those pictures before, they're simulations from the model. Well, they were just simulating things we'd actually done, I guess, in the trial, the 0.5 milligram per kilogram. But we can actually do things outside of that box. I mean, we've got to be careful. These are extrapolations outside of the data, but that's the key with modeling, is we're describing the system. And if we're describing the system, there's no real reason to believe that going mildly outside that box of the data that we developed, that the system's suddenly going to fall over. because we're just describing how things occurred using, standard representations of biology. So we can do some extrapolations. So I'm just going to swap out here, and now hopefully this will work. So this is what we call a Shiny app. We sort of write these because it makes life a lot easier to sort of demonstrate what we've actually got with our model. So we've got here 500 people. This is under the hood doing a whole bunch of number crunching. At the moment, it's showing 0.5 milligrams per kilogram subcutaneous. I could change that to an IV infusion, 40 minutes, 0.5 mg per kilogram, and it's showing the mean and the confidence intervals. So it takes a couple of seconds. There's trillions of numbers buzzing around inside here, and it will show us there. And so this idea that the cardiovascular effects are linked to those very high concentrations is important here, whereas the depression scores only require much lower concentrations because of the increased potency. So this is saying that if we dosed once a day for 5 days, we'd eventually see a fairly heavy response here. Bearing in mind, we've described the time course during the day as well, whereas it's routinely just measured here at the visits, I guess. So if we increase the infusion duration here to, let's say, half a day, I'm going to just drag that out. So that's a half a day. So we're giving exactly the same 0.5 milligrams per kilogram. We're just dragging that out over half a day. And I'm not saying you actually do this, but there are ways that we can get delivery like this. If we drag that same dose and took a whole day for it to enter the body, and then we'll look at what happens here. Just takes a second up down, sorry. So what we're seeing now is these very low concentrations of ketamine in the tens of nanograms per ml. They're effectively 100 times above the EC50 for depression, and they are hundreds and hundreds of times lower than 10 to 100 times lower than the concentrations that will cause any form of impact on the cardiovascular system. So we see zero impact essentially on the cardiovascular system, and we see consistent and pronounced and sustained knockdown of the depression scores because we've got a continuous exposure. So we could do the same thing and drag that out over a whole day, and it's really just going to show that fact. That we see no impact on the cardiovascular system. The concentrations are really low now. It's effectively a continuous infusion all day, every day, and maintaining a very low concentration that is 10 times higher than that needed, or 100 times higher than needed to knock down depression. And so we could eventually see good outcomes for everyone. So using a model allows us to play those scenarios out, to explore different regimens, different trial designs, and make informed decisions is what I like to refer it to, rather than educated guesses. So the limitations of this, these single doses, we don't know what happened really after repeated 2 times a week for 3 weeks seems to be a standard thing. We didn't have that in the time that this study was conducted. So there's potential for other effects to begin to come into play. We couldn't model any measures of the psychomimetic effects of ketamine. That data was not really amenable to modeling because of this very, very sparse nature in which it was collected. We didn't collect some potentially high active metabolites. And the last couple of points, in particular, pre-existing concurrent conditions, I'd like to just talk about. I'm not sure why that came up. Oh, no. I'm sorry, everyone. I might just swap out. And I don't know why those slides, so I'll just start my slideshow again. I'd like to talk about this for just a moment. This was a really interesting paper for me. This is a really interesting paper for me because it really beat home something that we sort of felt we were seeing a little bit in our data too, where Brittany O'Brien and colleagues presented at the Journal Club a while ago now, where they saw people who didn't respond very well but had significant depression, and there was another group that did respond very well. And when they looked at that, it seemed to be related to some prior childhood trauma, which had a better response, I believe, for people to ketamine. And I think that that's something that is really interesting. And unfortunately, we don't have access to that information. And that could be a really important thing to look at with our modeling up front, to sort of see if we can identify different trajectories, because we did see massive variability in the turnover, and there were people that did not show pronounced responses or very much response at all, and really I couldn't explain why that was happening. So I think I might leave that there and maybe just go back to the title slide.
Brilliant.
Okay.
That's really great. Thank you very much, David. There's a lot of absolutely crucial questions for us in that. It's addressing such important issues. So I'm really looking forward to the Q&A here. Yeah, Scott Smith, great question. Is there a way I can access the Shiny app?
Not really.
No,
not really at the moment. I mean, yeah, that's something we have to be a little bit careful with, but
sure.
Yeah, it's a bit tricky. But feel free to email me and we can have a chat.
Okay. And Tiago Gill says, Colleen Liu at the Ketamine conference showed us a trial with 150 patients and 0.5 mg per kg subcutaneous was not effective, and the trial was stopped, and then the dose was raised to 0.9 milligrams per kilogram.
Right.
And after 8 sessions, it did differ from placebo. So, well,
the original trial data that this is based on showed that it did work, but yeah, I'm not sure what happened there.
So different trial, I think, wasn't it? Yeah. So I think, well, maybe Tiago can come back to us on whether it was a different trial or not.
Yeah, this trial only had 21 participants.
Yeah, no,
that we used.
A different trial. It was a much earlier study in 2014, wasn't it? It was published. So
yeah, not sure what the differences are with that trial.
Yeah. So it's yes. So, but I think it's a really important question, isn't it? I mean, I guess it sort of speaks to the primacy of the clinical trial to answer questions, I guess. But so yeah, so I think the answer to Tiago's asking, did you use her data to make those simulations? And I think the answer is that these simulations are based on an earlier trial rather than the recent trial.
This trial on the screen, 2016. That's the trial that the data came from.
Yeah. So the trial that she presented in Oxford recently was a much more recent study. It's I think is going to be published. Yeah, it's unpublished. That's right at the moment. Right. So Scott asks again, would this data imply that an extended release preparation of ketamine sublingual or oral could potentially be more effective than 40 minutes IV infusions? And I guess that's really interesting because of Paul Glue's stuff with the long-acting oral preparation, isn't it?
Yeah. So I mean, can't speak about. We didn't have oral data in this. The only way that could differ is the exposure you get from a given dose to ketamine. And I guess metabolite concentrations, which I pointed out, we only had norketamine, and norketamine really was not responsible for the actions anyway. But the hydroxynorketamine may be active, so there may be some differences there with an oral formulation. Yeah, so sustained release oral formulation is one way you could do it. You could do this many different ways. We've got many different ways to have a sustained exposure to a compound besides oral as well. People do it every day with nicotine patches.
So,
yeah. I mean, that's the whole idea of that shiny app. That's why I showed, let's see if I can get that back up. Where's the shiny app? There. That's why I showed that, because that's exactly what that's saying. Is we're basically infusing the drug into somebody continuously for 24 hours. In other words, we've slapped on a patch and they're having a patch slow release for 24 hours of 0.5 mg per kg, or they've taken an oral sustained release formulation, something, here, multiple hours, or we could say a 12-hour sustained release formulation. Here it is, 12 hours sustained release. There it is. This is what the model's predicting. There are limitations here because we didn't really have day. We had day, week of dosing. So we don't know what happens really when you might administer multiple times in a row. That is the limitation that we have here.
David,
we need data.
Yeah. Just comparing your last, sorry to interrupt, but just comparing what you've just done with your shiny app. Is that if you take a day versus half a day, obviously for most clinicians, the thing that really matters is we're not terribly interested in the blood pressure and the pulse.
No, there's nothing happening anyway.
Exciting about that.
Yeah.
But it's the MADRS scores, and if you look at the difference between the sort of time to plateau in your MADRS scores, it looks as if there's not a great difference between a 12-hour administration and a 24-hour.
Nope, probably not. No, I mean, well, no, I mean, I don't mean probably. I mean, there isn't really. I mean, I can do that right now. So if we look at that snapshot, okay, and then here we go, you'll see it grey out, and I come back. It just smooths it out.
Yeah.
I mean, you're getting the same dose rate, okay? You're getting, you're getting the same similar-ish concentrations. And the point is that these concentrations are now constant, so it's consistent. Once a day, there's a little bit of wobble. But those concentrations, the potency on the depression scores is so high that those residual concentrations, even though ketamine's almost gone, it's not quite, is sufficient to maintain knockdown enough so that we only saw a little wobble in between the 12 hours. So we don't need 24-hour continuous exposure, no. So one of the good things about being here is I get to say this, is we don't have a lot of data for looking at repeated doses. So if people have that kind of data, that would be really useful for us to test our model with, or refine the model and make it even better and even more helpful to everyone in the world. So if people have data, feel free to get in touch. We'd love to be in conversation with you.
Well, there's a lot of people who do want to be in touch, lots of questions coming in. And Nuri Farber's obviously got a good question. So he says, based on your data, you'd argue that it's the duration of exposure that's important.
Yep.
Hang on, it's just jumped on me. Any sort of ideas about site of action? As you mentioned, these minuscule concentrations. But Nuri's done a study with 96-hour infusions.
That'd be interesting as well. So the site of action, no idea. It's probably central. I can't speculate on where that is. Ketamine works in many different ways, many different messy, dirty pharmacology. So I've got no idea. And remember, these are concentrations in the plasma. They don't represent actual concentrations around a receptor. They're the concentrations in the plasma that correspond to that effect. We don't measure the effect inside the concentration inside the brain, so they're just plasma concentration. So, but it's probably a different biological target to the cardiovascular effects, given the massive difference in potency.
Yeah, and Giselle Pickering is saying, they basically see the same thing in the differences in potency of ketamine for depression and cardiovascular side effects. The same sort of things observed in pain. So it's a sort of interesting thing.
So I guess that the good thing with this is now is we know for sure that there's no point in amping up the dose much further, I guess. That if you do, you're going to start introducing risks with blood pressure and heart rate. So
there's a lot to discuss in that. Given the wide discrepancy between previously reported ketamine IM, what's this? Ketamine IM something equals 93%, and your recent IM model estimated F equals C. Oh, this is the bioavailability of 64%.
Yep.
Can any other published admin route bioavailability data be considered accurate? So I guess this is inviting a comparison between your own data and other and previous estimates of the bioavailability of 93%.
There's been, in the paper we discuss that there's other papers where people are getting 70, 60, 80% for IM. No idea why it's not 100%, but certainly 100% did not work. I tried fixing it to 100% because logically to me, that means, well, that would be a logical number for me, other than some degradation at the administration site, which is potentially possible. But I wouldn't have thought it would be for a drug like ketamine. But it kept coming back to that number. And I spent many, many hours, and my computer ran for days and weeks trying to figure out if that was a good number or not. And that's the number we got. It can be explained by things like it's just such a slow release that we're not even seeing that. It takes slow. There's a second characteristic of the release or absorption profile that's so slow that it's not captured during the sampling times. But yep, it is what it is. I don't know what else to say here, but I can say we got to be careful with comparing studies with low numbers of subjects as well. I mean, if people could indulge me, I can show what happens when we run a study with 20 people. People have to understand the power of low numbers or the lack of power of low numbers. So I only go back and I'll just run this, something like that at an infusion, normal-ish duration. So we get that. Let's just look at what that looked like. They're down here around 10. This is spiking up here. They're around there. Let's run it again when we get another 20 people, random people. And now, it looks just somewhat different again. The results are not consistent when you have low numbers, right? See how these percentages are bouncing around? You need massive numbers to get a solid answer. But yeah, the IM, I don't know. I'm sorry.
Good, thanks. I'm going to just keep running through the Q&A actually. Did you split the women into two groups according to their menstrual cycle phase, since estrogen can induce CYP2B6? And there are preclinical studies out there showing that the effect of ketamine, especially low-dose ketamine, might be different when estrogen is in its highest physiological concentration. Yeah.
A lot of that data around sex differences in P450s is only ever seen in animals. It doesn't bear out in humans. But no, to answer the question, we didn't separate out. It is an interesting idea. Did not have access to that information from the trial data. Whether that trial data information exists or not, I can't say, but I certainly wasn't told the menstrual cycle of the female participants.
And the age didn't matter, did it? Because it's quite an elderly population in some ways. Their average age of
50. Yeah, averaging 50 years old. The youngest was 29.
Why? Any plans to look at the PK and P pharmacodynamics of intranasal ketamine?
Yeah, if somebody's got some data, that'd be fantastic. I'm happy to look at anything.
And
yeah,
Scott,
absolutely.
Scott points out that actually what you've suggested really upends the current treatment paradigm in the US.
Which is a twice a week for 3 weeks.
Yeah.
Or not really, I guess. I'm not sure how upends it exactly. Oh, because they go to longer durations at the end. So the twice a week's probably a pretty good idea to begin with, but yeah, it'd be much better to have continuous input, as we just saw, in my opinion anyway. But again, there's a big wrapper around this. We don't have long-term data. So we can't verify that nothing changes. Tolerance doesn't happen,
exactly.
Something like that.
Exactly.
I'm just going to keep saying that's the big wrapper around all of this.
Yeah, that's the worry, isn't it? That you keep dripping it in, and people get tolerant to it. We had some data from Holland, from the Netherlands, looking at 3 times a day, doing exactly what you've sort of suggested, which was 3 times a day, 30 milligrams orally, and it didn't work.
3 times orally, I have no idea what goes on after an oral dose. I wouldn't have thought it'd be yes or no, black or white, doesn't work. But they tried 3 times a day and it didn't work.
3 times a day at 30 milligrams of time, so very, very low. That's a sort of very low dose, really, 90 milligrams a day. So and if my memory serves me correctly, the result was negative.
How many people?
This was a big study, a decent study,
okay,
decent sized study.
Right.
Yeah, so that may be, well, that is what it is. Okay. But I think what Scott was meaning by upending the current treatment paradigm is, if the obviously the higher the dose, the more likely you are to get psychedelic effects.
Yeah.
And I know that we in thinking about, if somebody doesn't respond, then if they haven't had any psychedelic effect, we'll put up the dose until they So there's that sort of notion that the psychedelic effect is somehow important to it, and your data is sort of suggesting that it may not be.
Well, we didn't have those psychomimetic psychedelic effects. Well, I didn't have access to that data.
The data, yeah.
So maybe it is as potent, maybe they are related.
Yeah, obviously with the ketamine data, the long-term ketamine data suggests that you get tolerance to the dissociative effects, without getting any reduction in the remission. Yeah. Okay, so any ideas of other interesting metabolites? So you were pointing out that the hydroxynorketamine is you see that with the oral route, but not with the
No, not necessarily. It's there under the liver forms it. It doesn't matter how it gets in your body, your liver's going to produce it. So where were we? That's just the hydroxynorketamine. So there's some evidence out there.
There's norketamine and hydroxy.
Hydroxynorketamine. Yeah. So the 2R, 6R hydroxynorketamine, there's some evidence that it is actually pharmacologically active, but we were unable to measure that at the time.
Okay.
Not that it doesn't exist, it's just that we didn't have an assay for it.
Okay. So Shoku Arjman says, I've seen some papers indicating that S-ketamine has a biphasic half-life. I can't get it thoroughly. One peaks at 1 to 4 hours, and the second one at 7 to 12 hours. I'm curious to know your thoughts on whether there could be some clinical considerations in this regard.
By a double peak in the concentration time curve.
Yeah, well, that's what they're saying. They've seen some papers indicating this with S-ketamine.
Right. Well, there's only that. Okay, as pharmacokineticist, there's only one explanation for that, enterohepatic recycling. If we're talking after intravenous administration, there's no way you can get 2 peaks. There's just no way. The only way you can get it is if it gets dumped into your gut and then reabsorbed. Then you can see a second peak.
So
that's
it's very interesting, and just there's a clinical correlate here that we have actually that has been discussed at this forum, where occasional patients describe getting a second wave of dissociation. So that sounds as if that's a pharmacodynamic effect. Yeah,
well, I mean, see, the metabolite profile, the metabolite will, even after an intravenous dose, the metabolite will peak later than the parent drug. Right, it won't peak at the same time as the parent drug's injected. It's formed. So it could be a metabolite that's active, that's peaking a few hours later. If you talk, how long after the dose?
About, well, it varies, but, you know, half an hour to an hour.
Yeah, see, that could be a metabolite peaking. But after an intravenous dose, you can't have really, it's biologically impossible just about for a parent drug concentration to peak after a second time after an IV dose. The only way is it gets secreted into the gut through transporters in the liver and then absorbed the next time you eat something. And that's enterohepatic recycling. That's well known, and that does cause double peaks, but they usually happen hours later when you eat, not half hour later. So, but it could be a metabolite. The psychoactive effects could be a metabolite peaking, you know, half hour later, because that's when it probably would peak.
Oh yeah, so Shoku's saying that maybe that this was an intranasal administration. I don't suppose there's anything about that that would contradict that, would it? Doesn't make any difference.
No. Other than maybe if it sits in the nasal mucosa, I don't know, and then suddenly gets absorbed a while later. But a double peak in the plasma concentrations, no. Yeah. That's not going to happen.
Tiago asks about why your model ends up with 2 compartments.
Oh, okay. All this is saying there are 2 clumps of tissues. There are some tissues here that the drug gets injected into. The drug gets injected into the blood. So obviously the blood is here. That's all right. The blood's in this first compartment, and it will rapidly equilibrate with some tissues. We don't know what they are. Don't particularly really care. Some tissues it equilibrates rapidly with. So they're all, many tissues are involved here, and they all equilibrate at different rates. It distributes them at different rates, but overall they're roughly the same. So they appear as one compartment. Then we have another clump of tissues where the drug will distribute out of the blood into those tissues more slowly. Now, there'll all be slightly different rates at which the drug distributes into them, but it distributes into them at roughly the same rate. So we appear as another clump. Really, there's thousands of compartments in our body, but it just turns out for ketamine that when we model it, it looks like there's 2 general types, fast and slow. And that's why we have 2 compartments. This is very boring pharmacokinetics going way back. We could take a physiological approach and describe the body with actual blood flows and actual organs and partitioning into those organs, but we'd have to have samples from all those tissues for people, and we really don't want to do that, and probably don't need to answer the questions that we want to answer. So I'm not sure if that was okay.
Yeah.
No, it was hand wavy.
No, that's good. Scott,
while Rupert is reading through the question, David, can I ask you, based on your model, right, and this different concentration of ketamine and how it reflects in terms of the MADRS score and how really the curves change shapes, right, over the day. Do you think, and I do understand the limitation of my question because you were just like looking at one infusion over a week, but do you think this will have implication in terms of the duration of the response over time and then eventually the relapse? Or do you think that based on this model, we can really give like some information if this administration is daily or like repeated?
Well, I mean, the model was just based upon a single dose effectively separated by at least a week. So we don't know what happens if we get repeated doses closest together. But from that app, I showed you the simulations of, you know, what we think would happen if we do this repeatedly, day after day after day. You know, that's what we expect is going to happen. But whether or not it sort of matches what people see in the literature. The trouble that we had was I tried to compare our predictions to published outcomes in the literature for, you know, many doses, and tried to say what percent of people, what was the score, what percent of people. But the trouble is people are using all different scoring systems. They start off at all different baselines. And it makes it very hard. I tried using, what is it, a standardized normalized difference or something to try and get around using different measures of the depression scores. Yeah. And that really didn't work out. I tried to overlay it on our predictions and it didn't work out. And the other thing here, and this is partly why I was doing that before, is these studies where there's 20 people or 30 people, the numbers are going to bounce around everywhere because there's so much variability. So even if the model was, see, look at that, that looks nothing like what we just saw, you know, a second ago when I simulate a new trial of 20 people. You know, if we keep doing it enough times, it'll bounce down to like 25% by just pure random fluke, because there's so much variability. So yeah, I'm not sure if I answered your question.
So if you can I just ask, I was intrigued just to see the lack of difference between what happened if you had took a large number of patients and you had the 24-hour infusion versus a 12-hour infusion. Yep. There wasn't much difference. So then I'm thinking, well, what's the maximum, what's the sort of minimum duration of infusion, which if you gave it every day for 5 days would result in a sort of 75–80% remission. So
okay, so do you want me to I'll just crank this all the way over here. I'll put this up to, you know, 500 so we get something consistent. And you know, you're saying, so when we did the 0.5 for a continuous input, it was brilliant. Yeah, and you're saying how low can we go?
I was saying how long how low in terms of the
dose,
in terms of the infusion duration.
Can you give them a shot every day?
Yeah, leave it at 0.5, but
okay, yeah. All right, so leave it at 0.5. Whoop. Well, we saw what happened every half day. It looked pretty good, didn't it?
Yeah. But giving half a day infusion is a big deal. So can you do it?
Yeah,
what happened if you gave it for 2 hours instead of?
Oh, okay. I'll say 3. It's closer to 3. It's not going to be as good. This takes a second. I'm sorry. There.
All right.
Because now there's, you know, 21 hours for ketamine to be completely eliminated from the body, you know, as opposed to 12 hours before. So those concentrations need, once they drop below, you know, 0.5 nanograms per mil, it's going to start to wear off a little bit. I mean, that turnover buffers that process. So it's not immediately linked the outcome to ketamine concentration. There's a buffer through that turnover system that I described, but there we go. So that's 3 hours.
Okay. Thank you.
Models very nicely to Nori Faber, right? Work. And
exactly.
What Joshua presented here as well.
Sorry?
We had a speaker, I think it was the first edition of the Journal Club, and they had like this very, very long infusion. I don't know if Nori is still here, but the curator speaks very well to the kind of trial they conducted.
That's what can be done with a model, even if this isn't perfectly going to predict what happens longer term. It allows you to at least think about how you want to design the trials. So answering that question of Rupert's, like 3 hours, is that going to be good enough? You know, what happens if we go 2 hours? You know, let's have a look. 120 hours, 120 minutes. If we're going to drop it down to 3, why not try 2?
This is something that you're having to do every day.
Yeah, why not? 3, who cares? About the same.
Yeah, about the same.
Yeah. 2 is just as good as 3. So, you know, if you're going to drop it, if you're going to try 3 hours, well, don't bother, because 2 is going to be about the same anyway, right? So this is what I meant by informed decisions as opposed to educated guesses. Whereas before you'd go, well, worst try 3. Well, there's no point in trying 3. You may as well do 2. And if you may as well do 2, we may as well just do 1. And we're probably going to see no difference again anyway, right? 1 hour is probably going to look basically the same again anyway as 2 hours.
Okay, so we've got...
There we go. No difference. 1 hour, 2 hour, 3 hour. Just use 1. Just use 40 minutes. Why bother?
Okay. You know, I thought when we started this, you know, it was my bedtime, and I thought I'm never, you know, this is going to be, you know, it's going to be full of equations, and I'm not going to understand a word.
Nah.
No. And so I'm really delighted that it wasn't, and that I could understand. So that's fantastic. Thank you very much, David. And
no worries.
I think the volume of questions has been amongst the highest we've had. So that's great. Really, really interesting. But I've got one more, and it's one of the things that I can do. One of the things I say to patients is, I use an analogy, and your turnover thing reminded me of it. I say, you know, if you think of it as a bit like a pipe filling up with sand, and if you give intravenous ketamine, it sort of blasts it out. But the trouble is the sand keeps on coming. So if we give oral ketamine, it might just gradually just help keep the pipe clear. Now, it's a sort of clinical thing that I think it sort of helps people to understand, helps me to understand. But I don't know. And I always say, but I've no idea what that means biologically.
Yeah, I mean, this is what this turnover system is just a bucket being filled up by a tap, and the drug, is having, at the beginning the tap's wide open, and then the drug is just turning that tap down, and then the bucket slowly empties, and then when we take it away.
Can we say from your data that there is a sort of that turnover idea, that there's an active process that is continuing to go on, that is counteracted by ketamine, that there's some merit in that idea, so that depression is, the biology of depression, if you just say it's a biological thing, is that there's something continuing to accumulate that is shifted by ketamine.
I mean, this sort of thing is done all the time for, you can imagine a tumor growing, there's forces growing a tumor, and there's forces trying to make the tumor shrink, and a drug can either make it grow less quickly or kill it more effectively. I just make this is, we have a burden of depression, and your burden of depression my burden, anybody's burden of depression, is a balance of for forces acting to make it worse and forces acting to make it better. And depending upon your balance of those two things, you're either, here or here, and then the ketamine comes in, and to begin with, the tap's wide open. It is whatever it is for developing it, and ketamine just turns the tap down,
So that
and the more ketamine, and it doesn't empty the bucket instantly. It can't. The bucket has to empty, has to drain. So even if the drug is constant, we still see a continual drop for a while, and if we take it away, it doesn't bounce back, which is why it didn't shoot straight back up, because the tap has to refill the bucket. It takes time, even when the tap is fully opened again. So that's how we justified it. The publication of the journal article, one of the reviewers said, please try and put some biological plausibility to this idea of a turnover model. And you go, well, it's a thing. We did our best, neuroplasticity, whatever, but we don't really know what it is. But it's just a bunch of things making it worse and things making it better, and ketamine turns down one or turns up the other.